to begin the proceedings for the 6th Professor P. and Tandon Oration.
Thank you. Good morning, everybody. I welcome you all to the 6th Dr. P. and Tandon Oration for the day. And at the outset, I'll invite our Honorable Director, Professor M. Srinivas, Dr. Kale, Dr. Ashish Suri, and Dr. Chandra on the dais, please. Yeah, Dr. Kale and Dr. Chandra to be on the dais, please. May I now request our director to address the gathering?
Thank you. Good morning. What a blessings. I was just telling to the doyens, the first time where we see 4 generations of teachers. We used to talk about 2 generations, 3 generations. Now we have 4 generations of teachers. I think give a big hand to the organizers who brought all of them, including the alumni. All the people right from 1960 onwards, people have been invited and a lot of preparations were going on. Then how do we take a photograph of all the people in the background of the AIIMS auditorium? Sir and madam, it's always a blessing to see, and you have been the pillars of this institution. And then the youngsters, the other day we were saying that youngsters should know the history of the institution and the people, and this is an opportunity for all of us to see the people who have put their sweat, hard work, worked tirelessly, and brought these institutions and the departments, and whatever we are here, it's all because of you. And this is something which we want to express on behalf of all the staff, faculty members of the institution. A great gratitude to all of you, ma'am. It's a wonderful to see you again. Thank you.
Thank you, sir. May I now invite Dr. Ashish Suri to give us an introduction of the oration.
It's a very difficult thing to introduce your teacher and the legend in front of him. And this is the first time he's attending. This is the 4th, 5th one. All the other orations have been shared by Dr. Banerjee. So if there's any mistake in the presentation, sir, please let me know. So I have the proud privilege and honor to introduce the oration and the name of Professor P. N. Tandon. And this is our teacher, and this oration started a few years ago, and it was another legendary conference that we had under the Cerebrovascular Society of India. It was a very beautiful conference because it was chaired by the chairman were Dr. Mehta, Dr. Mahapatra, and Dr. N.K. Mishra. It was a combined, Dr. DP was there. It was a combined vascular neurosurgery, radiosurgery, and intervention neuroradiology conference. And we had a wonderful, and we managed to save a lot of money in that. And all the chairs said that we should, we proposed to the AIIMS that we should start an oration in the name of our emeritus professors of neurosurgery. So it was Dr. P. N. Tandon and Professor A.K. Banerjee oration on alternate years. And during this conference, with an eminent faculty of international repute taking this oration, to introduce Dr. Prakash Narayan Tandon, and this is more for the juniors, and born in August 13 in Shimla, 1928, did his MBBS from KGMC Lucknow, and always the first position, several gold medals, and then he did his MS in the Lucknow University, and did his FRCS after that, and then neurosurgery training and allied neurosciences in Oslo University, Norway, and in MNI, Canada. He founded the Department of Neurosurgery in 1965. That is, this is the true Diamond Jubilee, 60 years, and he is now the emeritus professor. He also founded as the founder president of the National Brain Research Center, now under the DBT, member of governing bodies of several institutions, and author. I think this is an old figure. He still writes and co-writes and guides the writing. So I would say probably 1,000 papers and monographs, and He's been the president of the NSI, the National Academy of Science, Allahabad, fellow of several national scientific societies like the National Academy of Medical Sciences, the INSA, the Indian Academy of Science, and the NASI. And the most important for, as a neurosurgeon and for AIIMS, that he has been the secretary, vice president, and the president of the Indian National Science Academy. He's been member of several national and international societies, several awards, huge number, I cannot count, including the BC Roy as well as Dhanvantri. But most important for the juniors, he's probably the only neurosurgeon, one of the few, AIIMS who has the Padma Shri, the Padma Bhushan, and the Padma Vibhushan, all three honored for him. So what I have learned from him, that stay hungry, stay curious, this is his word, but it's mentorship. He's mentored so many legends, again, who have mentored. So there are a lot of series of students and students and students and students of students which have come here. And these were the earlier ones which he mentored. And there's some we have lost over time. And these are all black and white. You can see me, the last row and the second last figure, I still had hair and I was pretty beautiful at that time. And then the colored ones came in, and now we have a lot of them, a lot of colored ones and young people who are doing a great job. And the first oration started in 2015 by Dr. Ohata from Japan, led by then Dr. Karapurkar in 2017, Dr. Mayank Goyal, who was also our alumnus from Neurology, Intervention Neurosciences, in 2019, and Dr. V.K. Jain in 2021. Then we had a break because of the COVID, and last year it was Dr. Ashwini Sharan from the US. And this time it'll be Dr. Dipankar Nandi, one of our senior alumnus and a very a legendary figure. Dr. Nandi, please.
Thank you, Dr. Suri. Now I invite Dr. Chandra to introduce speaker for the day, Dr. Dipankar Nandi. Dr. Chandra.
Good morning. It's really an honor to be here. Mentor. And the name after whom this oration has been done, Professor Tandon sir himself is here. And one of the few things which I have taken from him, which he used to often tell to me, is that I had a dream, but I was fortunate enough to have others to fulfill it. So today, sir, this is the culmination of your dream. And we are working very hard to fulfill your dream, and I hope we stand up to it. And I have a great pleasure of introducing Professor Dipankar Nandi. And since this is the 60th year, we have had both the orators from the alumnus, and Professor Dipankar indeed has outshone himself. He obviously has done his MBBS from AIIMS in 1989. And then MCH Neurosurgery in 1994. And then he moved to UK, where he did his MRCS from the Royal College of Surgeons, Edinburgh. And then he did his DPhil in Neurosciences from Pembroke College and University, Laboratory of Physiology and University of Oxford. And then finally he did his FRCS in Neurosurgery from Intercollegiate Specialty Board, Royal College of Surgeons of Edinburgh. He's got numerous prizes, awards, fellowships, invited lectures. For lack of space, we have only shown the most important ones. He's won the National Talent Scholarship from the National Council of Education, Research and Training, New Delhi. And then he was first in Armed Forces Medical College All India Entrance Examination. He also won the INLAX Foundation Scholarship and had numerous invited lectures. He's been very strong in research and has his own lab and has particularly contributed a lot towards understanding the connectivity within the brain, particularly in movement disorders. And these are some of the few research grants, which include Norman Collison Foundation Research Fellowship, Brain Travel Grant, Graduate Student Travel Award, Graduate Student Travel Award from Pembroke College, Affiliate Travel Grant, Physiological Society, MRC Strategic Grant, European Research Grant, Research Support Grant, Student Research Grant, I4I, NIHR Science and Technology Facility Council Grant, and so on. There are so many. and it would take us, I think, a lot of time to go on mentioning this. Against many more research grants. So he's been doing a lot of work in other areas, especially ultrasound and DTI guided resection of brain tumors using focused ultrasound, spinal cord stimulation for Parkinson's, spinal cord stimulation for gait disorders in Parkinson's, a remote intracranial pressure monitor, developing a de novo wireless system, remote intracranial pressure monitor, developing again a de novo wireless system. Then he's also won several bursaries from Newfield Science Bursary, Meniere's Society Prize, Berkeley's Fellowship, Finney Prize, and then multiple research projects. He's published very well in 125 articles, which are from very high impact factor journals, including NEGM and Lancet, and has contributed to very good 6 book chapters. And he has a lovely family. So I hear that Mrs. Nandi is from genetics. She is a professor of genetics, doing very well in her own field. He has a daughter, a proud daughter, who is doing a medicine from UCL. She is in the final year. Am I right, Dr. Nandi? She is in the final year. But these are all, I think, some of his passions. But I think that's his lovely family at UK. But one of his biggest passions happens to be, cooking. And he is a very good connoisseur of cooking various exotic food. I asked him if he has any particular tastes. He says he is quite good in most of the dishes. And these are a few other photographs. So, ladies and gentlemen, it's my proud privilege to present Professor Nandi to you for the Professor P.N. Tandon Oration, and we all look forward for it. So, Dr. Nandi, you can come and.
Thank you, Sarath. My mother couldn't have been kinder. So good morning, everyone. It's a real honor to give the Professor Prakash Narayan Tandon Oration with Professor Prakash Narayan Tandon in the audience. And what makes it even nicer is many of my trainers and teachers, including Madam Bhargav, who was the director when I joined, and many others who I trained with, Professor Kale, Dr. Vash, Dr. Prasad, in the audience. It is an amazing, really amazing honor, and I thank the organizers very much so. To have the director of AIIMS sitting here, the current director, and you say it's many generations down the line. One thing I will say, though, from what Ashish said, I didn't quite adhere to your thing, Professor Tandon. I didn't stay hungry. I decided to eat, and it shows. So we will get on with this. Just one more thing, to have teachers and to remember them. I think one has to fall back to Hindi. कहते हैं गुरु गोविंद दो खड़े काके लागों पाए बलिहारी गुरु आपने गोविंद दियो मिलाए. It is something we, I think, should adhere. It's part of our culture. This is a project which I started about 8 years ago, focused ultrasound. So the one barrier to ultrasound and the head was the bone, the skull. And a very clever Finnish scientist, Klura Heinonen, in Toronto and Montreal, developed this phase array system which gets enough sound beams, ultrasound beams to be exact. You're talking of 650 kilohertz frequencies to get through the skull barrier and focus, very much like what we've been hearing from Dr. Prasad. It's the same principle. You essentially have multiple beams of relatively low energy, whether it's ionizing radiation or sound. Each one in itself is rather harmless, or comparatively harmless to the substance it goes through. But where they focus, they generate enough, in this situation, enough thermal energy to cause a permanent ablation. And that is very much what this is all about. So we were lucky, we managed to attract funding. And as I say, I've been very fortunate. I've worked in 3 fabulous establishments, so AIIMS, University of Oxford, and Imperial College London. But pehla pyar to pehla pyar, nothing beats the AIIMS experience. I would strongly recommend it. But anyway, we kept incremental funding, and finally ended up with a machine. And now we have very recently acquired the 220 kilohertz machine, which is a lower frequency, allows a wider range of action, and that we are concentrating, I'll show it in the slides, in opening up the blood-brain barrier primarily to allow large molecules through. And that could be for anything, for oncology, for increasingly importantly, for cognitive disorder interventions. Just to put it in context, so we are talking about kilohertz. It's an order of magnitude different from the diagnostic ultrasounds, which are in megahertz. So it's just to remember what we are playing with. How do I advance them? So this is to show it is relatively new. The first randomized trial from Jeff Elias's group in Virginia, it is not that old. And from then on, we have moved on to, I think, up to date, more than 15,000 patients across the world have had focused ultrasound, mainly thalmotomies. And it's quite a rapid progression of technology. So it is a slide I've repeated across many international fora, particularly for trainees. It looks very pretty. The pictures are in multiple colors, but it is not a video game. The potential to cause damage is just as much as you're doing the difficult skull base, which Professor Suri showed, or you're doing a radiofrequency probe thalmotomy or any other invasive procedure. You have to know your anatomy, you have to understand the physiology and the particular physiology of your particular patient, and also, very importantly, what is it that they want out of this procedure? You know, a good-looking lesion on a scan is one story. How much benefit you're offering your patient versus what risk you're putting them through is an extremely important concept. That never changes, whatever form of surgery you do. For that matter, whatever medicine you do. So it is important you work in a team, very much true for all functional work. You rely heavily on your neurologists, and then there are additional people. This is a very radiology heavy sort of interaction, and often we would sit down and discuss our cases the week before. And I'll touch on these things. So at the moment, most of the work for ultrasound thalmotomy or ultrasound lesioning in the brain is for movement disorders. But this is a very real and very fast-moving field where much of this oncology and cognitive disorders work is going to be based on opening up the blood-brain barrier. But it is an important and reversible and repeatable phenomenon. So what it replaces, as things stand, is the old radiofrequency thalmotomy. And one would not knock this. This is from the 1950s, Spiegel and Weisses, Cooper, Mundinger, and a gentleman called Narabayashi. And I remember standing up in my ignorance in a conference and presenting my 3 cases, this was in Madras, I think, of RF thalmotomy, Professor Bhatia. And he comes up, I think he was invited plenary speaker. He said, very good. When I did my first 10,000, I thought, yes, I could do them. So, you have to know the people who went before you. But what radiofrequency thalmotomy, it works admirably. So the anatomy is established. The problem is you still have to stick an intracranial probe. And this is something which obviously doesn't enter in focused ultrasound. And another very important thing is, with the focused ultrasound, it's not an all or none phenomenon. You can incrementally increase the amplitude of sonication you deliver. You get to, and the final target on a thermal MR, which is happening real time, the patient is lying on an MRI table. You can see the temperature at the tip or where the lesion is or the focus, and you can have your neurologist examine them when they reach something like 50 degrees, 51 degrees, where it's a transient effect. If they are having adverse effects, you stop there, it's completely reversible. Likewise, if they have a good response to the tremor primarily with the absence of any adverse effects, you just make a permanent lesion there, deliver a higher sonication field. So it is, you have as much control as possible for, operating in the depths of the brain. So the other key comparator, and I shudder to mention this in the presence of greatness of radiosurgery, but gamma knife or cyber knife or any other form of stereotactic radiation, true, it is exactly the same thing. It avoids having to penetrate physically into the brain space. I think the one difference, I won't say advantage of MACPUS, just the difference, I'm a very diplomatic person, but is with radiation, with ionizing radiation, there is no immediate feedback. You kind of push the button and you walk away hoping you were good and everything is accurate. If you get it wrong, it'll be a bit too late when you realize it weeks or months down the line. So, quite apart from the dose of ionization, I think it's just a story. It's not that much anyway, but it is this feedback, the absence of the feedback. And hence, it is something to consider, but there will be patients, and there have been patients where, and I'll come to this, there is a concept, the skull, the morphology of your skull, the way the bone is made up is very important for focused ultrasound. And there is a way, an algorithm for calculating what happens to the sound waves as they go through the skull. And there will be a percentage of patients whose calvarium is such, the relative ratio of the outer and inner sort of hard cortex and the in-between cancellous bone, that there's too much scatter and you won't get enough sound waves through. The skull density ratio. I was part of the pilot group which researched and wrote it up. And it's a big thing if you're in Korea or Japan. Almost a third of their patients, just by the makeup of their skull, cannot have focused ultrasound. So there, I think, stereotactic radiation is completely legitimate and very important tool. So we started this journey as part of the 8 initial centers across the world in a multicentric prospective randomized double-blinded trial. And that ended in 2 years, and the results were extremely encouraging. So we managed to convince the health authorities in the UK. And so this is a battle you fight everywhere, by the way. It took us 5 years. 5 years from published, peer-reviewed, double-blinded data to get funding from the public health system there to fund it. And since then, we have gone on. I think we are reaching 300 now. So NHS England is our provider for funding, and you need them. You need them to go ahead, basically, treating patients free of cost. NICE is the National Institute of Clinical Excellence. So essentially, it's tasked with approving or disapproving treatments, not based so much on clinical efficacy, but also they look at the relative costs. So cost is a universal issue. I don't think you can have the luxury of practicing medicine saying it doesn't matter what it costs, I'm doing it for my patient. I think that is a fool's paradise. So this is what it looked like. That frame will be with Dr. Garg. This morning we put on a frame very similar. It initially was based on the CRW system, the Cosman Robert Wells. I don't think a better frame has ever been made, but unfortunately the company has folded, so we have others. The Vantage is probably the one which will replace it. But essentially the principle is very same. It is all based on Cartesian coordinates. So René Descartes, he was obviously French. He was in North Africa, I think in Algeria, part of the French Foreign Legion. He had malaria. They stuck him in a hospital, and he used to lie for many days and watch the ceiling. And the ceiling was like a checkerboard, like a chessboard. And he had nothing to do, no TV, no internet. So he was talking about 18th century. He used to watch the flies go across the ceiling, and he could see, okay, I could say, where is this fly with respect to that one by counting the number of squares to the right and then to the front. And that is the birth of Cartesian coordinate system. So as simple as that. In the depths of malaria, sort of delirium. The anatomy, and this is where you stand on the shoulders of giants, is absolutely right. A lot of what we do in functional neurosurgery, in anything, the basic scientists who found substrate out for us as to why would you do this and how would it affect the way the brain functions, that's the key. And this knowledge of what the pyridothalamic fiber tracts do, where they end up, what is the ventralis intermedius nucleus, the ventrolateral thalamus, what is the zona incerta. It's been known for 70, 80 odd years. And, over time, over 100,000 people across the world had thalamotomy. So we're secure in the knowledge a well-placed thalamotomy will control tremor, no matter what the origin of the tremor. And that's where you start from. We have done or people have done with the Fuchs ultrasound is that delivered it non-invasively. I work with a very eminent neurologist, Dr. Peter Bain, who's probably one of the foremost authorities on tremor. And this was his invention in the late 80s, the Bain-Finlay spirals. And it's actually a very good, and it's now been digitized, and you can actually objectively mark, it's a logarithmic scale, the improvement in tremor. So this is how this is Archimedes spiral. They draw the spiral on the piece of paper, what it looked like. This is what it looked like after a WIM thalamotomy. So that's at the ACPC plane. And then when we move further inferiorly to the zona incerta, which is at the dorsolateral tip of the subthalamic nucleus, you can see a further improvement. So this has been our strategy of creating 2 lesions in 2 different craniocaudal planes, particularly with patients who have a lot of proximal or postural tremor. And it is something we have published. It's something I had published about when I was doing radiofrequency thalamotomies in Oxford, where we used to do this repeatedly. And we showed that there is an advantage to the patient with the control of their dominant hand, if you're doing one side, to doing 2 lesions. This is the only thing to say is the imaging is again the key. You've got to be able to see what you're doing. And an inversion recovery MRI in any form, different companies have it differently. It's essentially a white matte and dulling protocol. So you should be able to see the border of the internal capsule, and then, which means you'll see the lateral border of the thalamus. I wouldn't bore you with too much of this. Only thing to say is we keep learning with time. So the first few years, we went the classical stereotactic coordinates of the ACPC plane and thalamotomy, talking to other centers, looking at our own results. So this was the results of a trial. So it's interesting actually. With the thalamotomy, these are the clinical rating scales for tremor, and those are the Bain-Finlay spiral scores. But in any case, this is what happened after month 1. And this was a rigorous trial-based, the protocols for assessment post-thalamotomy were rigid, and they went on for up to a year. And this is what you find. What you're left with at the end of 1 month is pretty much what you're left with lifelong. And that's replicated in DBS for tremor. That's replicated in radiofrequency lesioning for tremor. So it's very heartening to know. It's very, very unusual to have a recurrence beyond a month. Adverse effects, it is a very forgiving procedure, and we have had a learning curve. As we have learned to fine-tune the lesion, it is extremely rare. The first patient had chorea, and maybe it was my mistake. I had gone a bit too deep. It is unusual, though, even with subthalmotomy. But we got that one patient of chorea, which lasted about a year. But beyond that, there are almost no adverse effects to speak of. One caveat. What focused ultrasound did, quite apart from offering an alternative to DBS or radiofrequency lesioning, is offered surgical treatment, the whole door of surgical treatment for a whole host of patients who lived with their tremor with no other alternative once they tried propranolol and then progressively horrible drugs like primidone or topiramate or whatever. You see, once you cross the age of 75, the conventional movement disorder surgery options are rather limited because DBS is quite an arduous thing to think about, even radiofrequency thalamotomy, to do it invasively. Many people have medical comorbidities. So what we have concentrated on, and I guess true for other centers, is anybody on that 75 and plus age group, this is like a walk in the park in terms of their tolerance. And as we have got better, it's 1.5 hours, frame on to frame off, no anesthetic, no medication. It's a very, 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 in that sense, well-tolerated procedure. The oldest gentleman we did was an ex-Royal Air Force pilot who was 93 years old, and he was out playing golf within 6 weeks. So it is this, it allows the profile, the therapeutic index between the risk of causing adverse effects and that between beneficial lesioning is such a wide one. It is one of the main key advantages of this technique. Having said that, older people, up to 30 to 40% of them, will have a degree of ataxia and steadiness and may have a degree of dysarthria. So these are, we now routinely counsel older patients, even if they have no gait issues premorbidly, to practice walking with a stick. Because so that's the frame, and then this is the additional thing you use. It's essentially a plastic stocking. And the reason you stick it on the scalp is air is an extremely poor conductor of sound. Water, as you know, ultrasonologists will tell you, is an excellent good conductor of sound. So you need a water medium between your transducer array and the skull. And which is also why patients need to have a complete shave. They need to end up like Professor Suri or me, you know, because if you think about a fleece, a fur jacket, the reason it works is air is trapped between the hairs. That's exactly what will happen if you try this with somebody with hair. So that, so far the technology hasn't advanced enough. You have to take the entire hair off. You put this stocking, that holds the cold water, achieves two things, allows you a water medium, but also cools the scalp down, because a lot of the energy is absorbed by the scalp, and it's, you know, it could burn as the sound waves pass through. So that is how they look. This is just to say, this is the evolution of the target I was talking about. When we started in 2016, we would do religiously in the prescribed thing of the anterior posterior commissural line, that's a mid-commissural point. Gradually we found out, again with our own experience and discussing with other centers, that if you made the initial thalamic lesion slightly higher, about 2 millimeters above that plane, you got a much more reliable control of tremor, much more quickly, with fewer sonications, and lost it in a permanent lesion. So that is work in progress. This is how the thing looks. I am aware, Professor Kale tells me you have acquired, and I'm not surprised you have, a machine. It's coming. It's places like this which absolutely should have these kind of technological advances. So ours is a first generation, extremely old, creaky machine. I think you are going to have the all singing, all dancing exhibit, same company. Ours was housed in a GE MRI scanner. When they first made it, that was the only compatible scanner. Now things have moved on. Almost every major MRI is compatible with it. But that's how it looks. So you lie supine, your head is fixed like any stereotactics procedure through that frame, and the transducer array is fixed to the frame, and the whole thing is aligned with the MRI scanner. The first couple of procedures took us 8 hours. Now, as we have become slick, we have developed a team. The radiographers know what they are doing. We know what we are doing. You know, everybody's got their sort of routine. So we now finish it in 1.5 hours from frame on to frame on. Obviously, helps a lot in the tolerance and the comfort of the patient. This is what it looks like. So, you know, the standard landmarks, ACPC, slightly behind mid-commissural point, and the lesion, if you look at it pathologically or histologically, is there's a central necrosis, there's a bit of cytotoxic edema. So those are the permanent bits, and there's a bit of edema immediately around, as with any lesion in the brain. And that's the reason for having the unsteadiness in the first few days and weeks, you know, which spills across to the internal capsule or the cerebellothalamic radiation. So this is the same thing of making 2 lesions. I went to a presentation or meeting in Milan, and this was in aid of that, because we had very robust debate, as you can imagine, with the Italians about the wisdom of doing 2 versus 1. Just to say, the scales for so it's a logarithmic scale. So when you see improvement from 6.2 to 3.4, it's actually an order of magnitude better. And you can see this in their day-to-day function. So we have recently published our 4.5-year outcomes, and you can see between the non-treated arm and the treated arm, you know, the clear improvement in tremor scores. And again, it stays, what you achieve at the end of 1 month pretty much stays for years. So when the patient is lying on the scanner, or they're, looking up, they can actually be assessed by speaking, by looking at the pyramidal function, sensation, for if you're too posterior for tingling paresthesia, but also they can draw the spiral. And that's what Peter gets them to do. So this is what we started with. By the end of treatment, this is what we ended with. So, and, the handwriting, they couldn't even put pen to paper before. For some reason, my neurologist loves Mary Had a Little Lamb. He sticks to basics. So we all know that rhyme by now, but only the first line. This is how it looks on the console. It's a thermal MR, so you can see it. And the color scheme is, it's like any other. You can make it look whatever you like, but red for hot seems reasonable. And so there are certain things, and when you start using the machine, you do have a lot of information feeding back to you. So that's a temperature time curve, but you also have what is known as cavitation curve. So it just tells you how smooth your sonication is going through. And these are important because it's energy. And if you get it wrong, if it bubbles too much, there are risks of causing cavitation, essentially cellular burst or fluid burst deep in the brain. This is just more of the same. But just to say, sometimes a single lesion works just at that superior plane. So this was one patient who from that went to that just with a WIM thalamotomy. So clearly we didn't proceed any further. We stopped there. That's the same patient writing her name. And it is, even I get impressed each time I see this. From writing like this to writing this, it's quite remarkable. This is just to say the thalamus remains a very mysterious place. There have been so many iterations of thalamic nuclei classification, so many names, particularly in the 50s and 60s. We still don't know a whole lot about it. Why does deep brain stimulation, work so well in augmenting function, whereas a thalamotomy, which is a lesional thing, or even a subthalamic nucleotomy, which is work too as well, because if there's a dichotomy in how we, as with everything else, I think it's a balance, a lot of plasticity plays into it. But just to say, we are at the very sort of basic end of our knowledge of neuroscience about how the brain works. And this is just for movements, which is a simpler bit. Think about memory, cognition, how a child learns. So yeah, AI and all that, but I think the human brain will take a lot of beating. This is just to say, so we have access to a 7 Tesla MRI. So we are running a few patients through them, especially the ones who failed despite a well-placed thalamotomy on scanning. The tremor control failed or wasn't good enough. We're trying to find out, was it the tracts? So also some of these scans can parcellate the thalamic nuclei, one different from the other within the ventrolateral thalamus. So always something to look for. That is the obligatory video. This is one of our initial trial patients. So that's Professor Gadroich, my colleague neurologist. This is Peter Bain. So that's after, you can't do a movement disorder talk without one of these videos. I think it's. So the initial licensing by the FDA, by the Council of Europe, and now by the UK authorities is all for a one-sided unilateral thalamotomy. So that's moved on now. Apart from the UK one, the European Council, the Japanese, and the FDA have all approved bilateral treatments. And we, as a trial, have performed about 25 of these. It's eminently doable. Again, we all rely on our experience from surgical days, radiofrequency or DBS. As long as you space them in time, and we tend to wait at least 6 months between the two sides. Some centers do them simultaneously. And as long as you are able to sculpt the lesion, and this is a great benefit with ultrasound, you can sculpt it so they are not symmetrical, they're not mirror images. That way, from previous experience, many groups with radiofrequency, we know that risk of dysarthria, the risk of dysmetria or ataxia is much higher. We have found bilateral focused ultrasound lesioning actually seems to have a much lesser profile of side effects compared to bilateral RF lesioning. So just to say, this is, a whole host of groups are involved. And to be fair, industry is a vital player in this. We often meet as users groups with industry, and there have been fine tuning. So the machine you are going to get, we have had some contribution to the enhancement from our system. There are a few papers we published on focused ultrasound along the way. But this is the thing. This is just the beginning. So Parkinson's is an obvious corollary. There is a lot of evidence of subthalamic nucleotomy in Parkinson's disease anyway, but particularly for tremor-dominant PD, this is an obvious choice. And yesterday we did with Dr. Garg, with the honor of doing a parallel DBS. You can do a parallel lesion. And, because of the nature of the technique, you can actually morph it depending on the individual patient's pallidum or medial pallidum as seen on MR. So, and other kinds of, tremors, focal dystonias, and people have done. There have been case reports on all of these. Now, this is the bit we are excited about. Our machine is still in a crate. We are trying to so we also have our regulatory sort of cross to bear. So it has been sitting for 6 months in a crate because the MHRA is our licensing agency, is still thinking about allowing us to use it. But once we get it, we will use it to open the blood-brain barrier. And there are a lot of trials planned, both oncological and with our colleagues in cognitive research, to try and transiently open up the barrier, allow these molecules in and see what therapeutic effects they have. And again, I'm sure you guys will acquire it soon enough. There are just the odd publications about direct lesioning in brain tumors. Liquid brain biopsy is a new concept coming in for Parkinson's disease based on imaging. Other disorders, particularly psychiatric disorders, and Professor Tandon will be aware of stereotactic brain surgery actually owes its origins to psychiatric work. So, depression and all. Obviously, at those days, the imaging wasn't anywhere near what it is now, and hence a lot of things went down south. But it's now definitely going to be an option, especially with non-invasive surgery. Pain, we actually have treated patients with pain. It's intractable pain is a very difficult nut to crack. Even now, the best quoted results with whether it's spinal cord stimulation or particularly with motor cortex stimulation or DBS, 50% improvement in 50% patients means you are doing extremely well. So that's a pretty unsatisfactory situation to be in. I used to do a lot of radiofrequency singulotomies, particularly cancer pain. It does work, but that is an option you could do with the ultrasound now, provided they have the treatment envelope. As it happens, as it stands now, the machine allows you a very restricted focus, which is pretty much a centimeter or even less around the ACPC line. Now that limits its application. To get to the anterior cingulate, the classical target for pain, you actually have to go a bit further anteriorly. So these are limitations which I'm sure the industry and the physics will work out, but they will become options soon enough. Dementia disorders are, I think, they will dwarf the frequency of application of these kind of techniques in time to come. And so far, at least, the main focus is on opening the blood-brain barrier. But soon it will come to actual destruction of plaques. There's a whole host of debate going on about the plaques are just a symptom of the problem or the origin of the problem. But in any case, given where populations are heading, the average age people are going to be, these are going to be important part of research and then hopefully intervention. Oh, this is just to say, my mother is a Sanskrit teacher, so when I set up the group in Imperial, you probably can't see it, it's Jnanam hi susasasya pratikam. The path to good health is through knowledge. And I've inserted it in every, but they do their Latin. I thought we should do our Sanskrit,
which predates Latin by a few thousand years. More applications, dissolving clots, just like using ultrasound to suck it out, or like a cavitation thing, like a CUSA. You can do it non-invasively. So this may not be the latest, but this is generally where we are with focused ultrasound in the brain. I think there are at least 70 centers, and this is the kind of number of patients treated. And people publish regularly because it's a new field, and the safety profile remains very robust. That's a part of our team. Obviously, a lot of people. I'm very proud. Nikhil joined me as a sort of medical student many, many years ago, and then became my resident and fellow, and now I managed to get him appointed. So yeah, I think fostering and mentoring our juniors, I think, should be part of, as we have benefited from, people like Professor Tandon. And that's it. Thank you.
Thank you, Professor Nandi, for a wonderful oration. We all enjoyed it and looked at the advances that you have contributed to. May I now request the dignitaries on the dais to present the award to Professor Nandi. So, citation as well. So, just keep it in. Yeah. Okay, thank you. I'll now call upon Dr. Kavalji to propose a vote of thanks.
Thank you, sir. It is my privilege to propose a vote of thanks for this wonderful oration on behalf of the Institute. We are really thankful to Professor Nandi for delivering this insightful oration. And as we are about to get this machine, this talk will be very, very helpful to us in starting this new modality for our patients. I would also like to thank Professor Tandon to be here because his presence is very special to us. I'm thankful to Madam Bhargav for being here. I'm thankful to Professor M. Srinivas for taking out time out of his busy schedule to be here. And I'm thankful to all our special dignitaries like Professor Sharma, Professor Sandeep Vash, Dr. Agarwal, Dr. Madan to be here. And now I invite all of you to join us for high tea. Thank you so much. I have some housekeeping announcements to make. We'll have valedictory function today evening. After that, we'll have a group photograph. Thank you. Yeah, we have kept some special prizes for the delegates. The delegates who have been most interactive during the workshop, during our this live surgery, DBS workshop and microneurosurgery workshop, please do attend the valedictory function. Thank you.